Welcome to Orthopedic Grand Rounds this morning. The topic is child abuse and its relationships with orthopedics. Our speakers this morning are Dr. Mark Miller, an orthopedic R3 in our program, Dr. Tom Jinguji, a pediatrician working in our Department of Pediatric Orthopedics, who's our pediatrician renaissance man. He's a great educator in our department, a wonderful practitioner in our department, and is extremely knowledgeable in orthopedics. His orthopedics knowledge ranges from club feet to sports medicine to fracture care, and he is going to join Dr. Kenneth Feldman, who's a bit of an icon at Children's Hospital for both protecting children's health needs and for diversity at Children's Hospital. He has a 37-year career there, been recognized by the American Academy of Pediatrics on multiple occasions for his work in the critical topic of child abuse. Child abuse is involved with almost 2,000 deaths every year in America. American society has 10 times the rate of some of our European cultures, and in times of hard times, unfortunately, the problems with child abuse seem to increase with an alarming incidence. So I'd like to introduce our first speaker on this very important topic, Dr. Miller.
I want to thank Dr. Conrad for the introduction. I'd also like to thank Dr. Jinguji and Dr. Feldman for being involved in this very important talk. And I want to thank everyone here for participating. My name is Mark Miller. I'm one of the fourth-year orthopedic surgery residents here at the University of Washington. First, I wanted to start out to define what is child abuse. What is our topic today? So the Federal Child Abuse Prevention and Treatment Act is the organization under the federal government that helps control and assess child abuse as well as follow it from an epidemiologic basis. But in 2010, they gave the definition: any recent act or failure to act on the part of a parent or a caretaker which results in death, serious physical or emotional harm, sexual abuse, or exploitation. Also, we'll talk about neglect, an act or failure to act which presents an imminent risk of serious harm. First, start with a question to the audience. This is a question from this last year's in-training exam. A 13-year-old girl presents to your office for a routine scoliosis follow-up exam. During the physical exam, she reports to you that she has been sexually abused by her physical education teacher for the past year. What is your next step in management? You inform the patient's parents of the allegation, but do not contact Child Protective Services. Provide reassurance to the patient that you will not disclose any confidential information without her permission. Contact CPS to investigate the allegation. Inform the patient's parents of the allegation. Contact the patient's school to have the educator reprimanded. The answer to this question is that you need to contact both Child Protective Services because she is a minor, as well as inform the parents or the caregivers. It's very important to recognize sexual abuse and other abuse, and you are legally and ethically obligated to report. Let's go a little bit over the outline for today. First, I'm going to discuss epidemiology of child abuse and how it's changed over the past 20 years. So a little bit about the history behind child abuse. I will also discuss associated traumatic injuries as well as the appropriate workup for such injuries. Dr. Jinguji will discuss a little on physical exam as well as on the specifics of orthopedic injuries and fracture patterns. And we are lucky to have Dr. Feldman here today to discuss the ethical and legal responsibilities of physicians in regards to child abuse. Our second question for today, this is another in-training exam question. A 5-month-old girl has been fussy and not moving her left leg for the past 2 days. Examination reveals swelling of the left thigh and the right knee. Radiographs are shown in figures 1A and 1B. What is the most appropriate management? What you can see is a mid-shaft femur fracture on the left, as well as a corner fracture here on the right. So what is the most appropriate step in the management? It's to obtain a DEXA scan to rule out osteogenesis imperfecta, order laboratory studies including serum calcium, phosphorus, alkaline phosphatase, and vitamin D levels to rule out rickets, apply bilateral hip spica cast and set up an office follow-up in 1 week, or admit the child to the hospital and refer to Child Protective Services assessment. Because this child is 5 months old and non-ambulatory, this is considered child abuse until proven otherwise. And the child needs to be admitted and have appropriate workup, which we'll discuss later. I also want to briefly introduce our 2 case discussions, which we'll discuss in detail at the end of this talk. These are both recent cases here at Seattle Children's Hospital. Case number 1 is an 8-month-old male with left elbow pain. The mother reports that the child's father lifted the child from his bassinet. Just a little about his history. He's a full term. He's met most of his milestones. Lives with his mother, father, and paternal aunt. The father has a history of PTSD and schizophrenia, but no drug history. He has a normal neurologic exam, but has bruising in different stages of healing on his back and buttocks. Here's a picture of a skeletal survey. You can see on the right is a type 1 supracondylar fracture, and on the left we have a distal radius fracture that is in process of healing, approximately 2 to 3 weeks old. Also on the skeletal survey is a distal tibia fracture. Also a CT scan which showed a chronic frontal subdural hematoma. The patient was admitted to the hospital with scan team and social work involvement. Introduce case number 2 is a complementary case. It's a 3-month-old female who stopped using her right arm 2 days prior to presentation. No trauma history was noted from the mother. It was unclear what exactly had happened. She's a healthy, full-term child. She lives with mother, father, and 6-year-old sister, and no family drug history. It's a normal physical exam, no bruising, and no other suspicious history. Here are radiographs, which do demonstrate a proximal humerus fracture. I'm going to go back to our definition of child abuse, so any recent act or failure to act on the part of a parent or caretaker, which results in death, serious physical or emotional harm, sexual abuse, or exploitation. The most recent data that we have is from 2008 from the federal government, CAPTA. So 772,000 children were victims, and there were 1,740 deaths. 71% of these cases were neglect, 16% were physical abuse, or those known as non-accidental trauma, 9% sexual abuse, and 7% psychological maltreatment. Fortunately, the incidence over the past 15 years is decreasing. Although we did see an initial increase from 625,000 cases in 1980 to 1.5 million cases in 1993, we have now had a decrease to greater than 700,000, which is still a significant amount. Physical abuse, the definition of physical abuse by CAPTA, is non-accidental physical injury that is inflicted by a parent, caregiver, or other person who has responsibility for the child. The medical term is non-accidental trauma. And there were 130,000 victims in 2008. Well, about the social factors that go into child abuse, one thing to keep in mind is that child abuse can involve any living situation, any family across all socioeconomic and racial boundaries. However, that when the family income is less than $15,000 per year, there's a 25 times higher rate of abuse than families who make more than $30,000 per year. It's risk factors that should be considered for child abuse are single-parent homes and substance abuse in the parents, psychiatric illness, as well as unemployment. In 1992, Kowal in Clinical Pediatrics, a large case series, showed that 72% of abuse cases involve substance abuse by the parents. The child risk factors are prematurity, disability, especially cerebral palsy, as well as stepchildren. A little about the historical background of child abuse. One of the first landmark papers ever published was by Ambrose Tardot, a French professor of legal medicine. He described the bruising patterns as well as musculoskeletal injuries in infants before radiographs were around. There was not much in the literature until 1944 when 2 neurosurgeons, Ingraham and Matson, published in JAMA the traumatic origin of subdural hematoma. They postulated the acceleration-deceleration cause of subdural hematomas. And this was at a time before CT scans and MRIs, and subdural hematomas were determined by angiograms and the blood vessel displacement based on the angiography. In 1946, Dr. Caffey, an American Journal radiologist, discussed the association between multiple fractures and subdural hematomas that he noted in children. However, not once in his paper did he discuss that these may be related to abuse or non-accidental trauma. The first papers that discussed the non-accidental trauma was Dr. Kempe in JAMA in 1962. He coined the term battered child syndrome. He was the first major author to acknowledge caregiver involvement in child abuse, as well as the association between fractures, subdural hematoma, and death. And in 1970, the Child Abuse and Prevention Treatment Act was enacted by the federal government, which allowed for us to follow child abuse and hopefully prevent it. And in 2009, the Academy of Orthopedic Surgeons got involved in their pediatric clinical practice guidelines that children younger than 36 months with a diaphyseal femur fracture should be evaluated for child abuse. This was a strong recommendation. A little bit about the clinical history that you would expect with in child abuse is that often there will be a delay in presentation. A child has been in pain for 3 to 5 days. There's also history that is inconsistent, lacking detail, or non-existent. Also insufficient mechanism of injury, and Dr. Jinguji will talk more about the mechanisms of certain fractures, but when the story does not match what you see clinically, your suspicion should be raised for child abuse. In children less than 3 years old, but especially less than 1 year old, should definitely raise your suspicion if there's any injury involved. And again, the child may have disabilities, behavior problems, or prematurity. There are important things to look for on if someone comes to your clinic or someone you see in the emergency room that's concerned for child abuse, and it's important to do a complete physical exam. Even as orthopedic surgeons, we're still physicians, and we still should examine the child thoroughly, and that includes a thorough skin exam, looking for the common places that have bruising, including the upper arms, the lower back, and the buttocks. And this is especially important if you have a child who has a femur fracture and you're going to place them into a hip spica cast. It's very important to document these bruising these findings before placing that cast. These may never be seen again. Also, burns, specifically cigarette burns, are quite common. It's important to do a neurologic exam, looking at pupils for pupil asymmetry, bulging fontanelle. The neurologic injury leads to the highest morbidity and mortality in abuse. In 2008, there were 1,200 deaths related to neurologic injury. In 2008, there were 8,000 cases of subdural hematoma. There's a fairly high risk of death when neurologic injury exists. However, in 2003, from Children's Hospital of Philadelphia, Dr. Rubin and his group looked at occult head injury. They did CT scans for all children less than 6 months of age and found that 92% of children who had subdural hematomas had no physical signs of neurologic injury. This is leading us to recommend routine CT scans for children less than 6 months of age. It's important to do an abdominal exam and abdominal history for nausea, vomiting, and distension. Hollow viscous injury is the second leading cause of morbidity and mortality. Up to 60% of children with hollow viscous injuries will go on to die. And that nausea and abdominal distension are the most sensitive for injury and should raise your suspicion to obtain a CT scan or general surgery consultation. Again, the importance of occult injury that Dr. Lane and his group from University of Maryland in 2009 did laboratory screening with amylase and lipase in children less than 2, and with abnormal laboratory values did CT scans that show that 40% of these children have abdominal injuries. Fortunately, the children that had these injuries, they had required no treatment for their abdominal injury. If you do then suspect a child abuse, what imaging should you obtain? The first, most important thing is getting the CT of the head, especially for children under age 6 months. If anything is suspicious, including bruising around the head, face, any sort of symptoms, you should have a low threshold for obtaining CT scan of the head. Also, performing a skeletal survey, and this is both at the time of presentation, you also within 2 weeks after presentation to see any evolution. And a skeletal survey is defined by the American College of Radiology in 1991, includes an AP and lateral of the skull, an AP and lateral of the axial skeleton or trunk, AP of both arms, forearms, and hands, as well as AP of both thighs, legs, and feet. One thing to consider is that physical abuse is much more common than bone fragility diseases, but it's important to, if your history does not make sense, to also keep in mind that this could be a disease of bone fragility. Looking out for osteogenesis perfecta, looking at blue sclera, triangular facies, and also looking at their teeth for tooth decay. Also important to keep in mind, just because a patient has a disease of bone fragility does not mean that they cannot be a victim of abuse. If you're concerned for other in your differential for a disease of bone fragility to obtain bone metabolism labs, calcium phosphate, alkaline phosphatase, vitamin D, to search for rickets. As you can see on the X-ray on the right, osteomalacia with typical physeal cupping, widening, and bowing of their lower extremities, as well as flattening of their skull. Also looking for hyperparathyroidism, which can show subperiosteal reaction, which can mimic fracture, as well as asymmetric osteopenia. Also, another mimicker of child abuse can be hematologic diseases. So if you're concerned, obtain a CBC, and if you're a very high suspicion, obtaining a bone marrow examination. That acute lymphocytic leukemia is the most common malignancy of childhood. As you can see here in the X-rays, that the radiographic signs of leukemia or metaphyseal spurring, widening of cranial sutures, and generalized osteoporosis. Last question, and this is also a question from the in-training exam: which of the following fractures is commonly associated with child abuse? Distal humerus physeal separation, displaced tibial tubercle fracture, medial epicondyle humerus fracture, or extension type supracondylar humerus fracture? The answer here is the distal humerus physeal separation, which is of moderate specificity. Next, I'd like to turn the podium over to Dr. Jinguji to discuss more in detail the orthopedic aspects of child abuse as well as fracture patterns.
Mark, thank you so much. Dr. Chapman, thank you for having me here. I really appreciate being here, and it's quite an honor. So my name's Tom Jinguji, and I'm a pediatrician that works in the Department of Orthopedics and Sports Medicine at Seattle Children's Hospital. And Mark asked me to talk about the no-brainer fractures that you always need to think about. And what I really want to talk about, too, in addition to that, is what you guys will see. And I think as orthopedic doctors, you're going to get called down to the emergency room, and they're going to say, does this seem right? Does this seem like this is okay to you? And that is a really, really tough charge to have, whether that's here or in another setting when you become a world-class, famous sports medicine surgeon, but you still have to take ER call in, I don't know, somewhere in Colorado. You might see some kids and they'll say, is this right? Or you'll ask, is that right? And that's the stuff we want to talk about. Mark's talk was incredible. It talked about so many things that are remembering the abdomen, that's here, remembering all these different things about leukemia and stuff like that. Those things are hard. And one thing I want to talk about is to know that's great, but also to realize that you are going to be part of a team when you're doing this. This isn't you alone out there, hopefully, but we'll talk about that more as we go forward. I have hopefully it's about 14 minutes at the most. So again, in that state, there's something called mandatory reporting. You have a reasonable cause to believe. All healthcare professionals, if they're concerned that this could be a fracture, you need to talk about it. And all 50 states have a similar law. So we're going to try to understand which children should be evaluated for child abuse and non-accidental trauma. So much of this will be age-related. Almost all the fractures that you're going to see, and it's really about fractures, because you're not going to get called to the emergency room for bruising. I hope not anywhere. They're going to say, oh, there's a lot of bruises, let's call orthopedics. Well, they might. But fractures are what we're going to talk about. And the thing about it is 80% of the fractures that you're going to see that are abuse-related are going to be in children pretty much under 18 months or 2 years. If you have children over 5 years of age, the risk of fractures from abuse is vanishingly low. You might have some adult who hits his child with a baseball bat, but that's going to be really, really rare, and those children will be able to report that as well. So really, we're talking about the kids 5 and down, or even really more 3 and down. So very much age specific. We're going to talk about some specific fractures and fracture patterns. We're going to talk about, for one specific type, long bones. History is vital. Sorry, but you got to talk to your patient. History is important. So let's go over what the American Academy of Orthopedic Surgeons says. So there is a advisory statement from the American Academy of Orthopedic Surgeons describing domestic and family violence and abuse and your responsibilities. It's a very nice statement. It talks about simple things like making certain you treat the whole person, making certain that you understand that there are risk factors, knowing those risk factors, doing a complete exam. The other one, Mark already mentioned, is a clinical practice guideline from 2009. Some of the folks in the audience were very, very vital in developing this guideline. Treatment of pediatric diaphyseal femur fractures. Their first recommendation was we recommend that children younger than 36 months with a diaphyseal femur fracture be evaluated for child abuse. So that's a strong recommendation. And if you try to follow within that, that would be one thing that you would want to know. All children at 36 months with a shaft fracture of the femur should be taken a look at. We'll talk about that in a bit. Okay. Also, what the books say. One of the Bibles for fracture care in pediatrics is Rockwood and Wilkins, Fractures in Children. And what they say is these are high specificity fractures. Any metaphyseal lesion, posterior rib fracture, scapular fracture, spinous process fracture, and sternal fracture. Any metaphyseal lesion, that's a lot of fractures. I mean, that metaphysis is that part of the, you guys know this, part of it goes from skinny to fat, right? Up near the ends of up near the joints. So that's a lot of fractures, isn't it? But then you have to remember that this is actually adapted from a guy named Kleinman. Kleinman is this big-time guy who wrote a lot on radiology. And when he really talked about this, he's talking about the kids under 2 for these very specific fractures, okay? So it's not any metaphyseal fracture. And you guys already know that. You guys take your OID. And the real metaphyseal fracture I'm talking about is the classic metaphyseal lesion for child abuse. It's also called a corner or bucket handle fracture, the old terms. I'm going to scoot forward just for a sec. And Mark already showed these to you, but these are nice classic metaphyseal lesion. These calls a chip or a corner. Chip or a corner. This down here, if you look at this, you can pretend that looks like a bucket handle fracture, that roundedness. This also roundedness here. This is not my forte, but I believe that this is supposed to be the primary spongiosa layer. This is the of the metaphysis. This is the physis, and this is the hypertrophic zone and the zone of precisional calcification. So the fracture goes right through the primary spongiosa, and at the edges will sometimes include part of the growth plate. And these fractures are complete fractures, and the difference between a corner and a bucket handle is all radiographic. If you look at a bucket from one stand, you'll see the handle. You turn it 90 degrees, and you see that little corner. So these are the same fracture, but these are the corner and the bucket handle fracture. Let's go back. So you guys know this too, but why is this so pathognomonic? Think about another fracture that is of the tibia in a slightly older child, about 18 months. It's called a toddler's fracture, right? How do those occur? You guys know this. They talk about kids walking and their legs twist. Or the most common injury now is kids are going down a slide. They're being held by some parent, or an uncle or aunt. The child goes down the slide. The leg gets caught on the edge of the slide, and it twists. Twist, twist, twist. And you say, well, what's the difference between that fracture and this fracture? That fracture, you have compression. And compression across the growth plate provides stability. And the fracture will go in the diaphysis, often in the distal third of that, which hopefully you guys saw that at Children's. These fractures involve distraction or tensile force across the growth plate with shear. I almost stepped on this morning. These are Legos from my 5-year-old son, James. And this is kind of how I think about this too, is if you have a growth plate, multiple layers, and it's pressed down, it's going to be fairly stable. But if you pull apart the growth plate, it's going to fall apart. Don't step on these, by the way. So these fractures are from kids that get shaken back and forth, and that force, there's shear across the growth plate, and that's what causes that. So one of the postulates is shaking. Another postulate is the kids are getting pulled and twisted. And I'm upset with my child because they're diapering, and I'm going to twist their leg. So it's pulling and twisting. It's distension or shear across the joint. Often the distal femur or proximal distal tibia, seen in children under 18 months of life. You'll see these little tiny clip fractures in kids 2 and 3, and it can be other things. They can be mimics. So remember, this is again age-based. And sometimes I'll see that little tiny chip, and they'll say high concern for abuse in a 3 or 4-year-old child. Sometimes I'll bring that up with Ken and his group. Other times what I'm going to do with that exact same fracture, I'm going to say, I just don't see the risk here. I'm going to bring them back in about 5 or 10 days and get another x-ray. If it's a fracture, or a week, what's it going to show? It's going to show periosteal reaction. It's going to show fracture. It's going to show a lot of things. If it's a normal variation or just a little tiny beak, it's going to be the same. Does that make sense? Okay, let's move on. I'm behind. So here again is another classic metaphyseal lesion right up at that upper edge. So the next fracture that we're going to talk about is the posterior rib fracture. And the posterior rib fracture, again, it's the mechanism that we think about. Remember that same child that gets squeezed and gets moved back and forth? Squeezing of the bones around the back of the rib, around the transverse process here, causes a lever, and you get a tension force right here or a tension force right here. And you can often see these fractures. Okay? You can also get squeezing, but not squeezing around, but just squeezing backward to forward, and you'll see these fractures that aren't considered as much classic posterior rib, but more lateral fracture. Some people still call this a posterior rib fracture. And here again, you can see, hard to see, but there's a little fracture here, and you can see this on the 3D CT. Nicely seen. Posterior rib fractures, really pretty much, I should say kids. All rib fractures in kids under 2 are really concerning for abuse, okay? The important thing for you as orthopedic surgeons is how often are you going to see a child with these fractures? That isn't going to be the presenting complaint. These are going to be things that they'll see afterwards as they get these skeletal surveys that Mark talks about. So these fractures are not going to be something they're going to call, hey, can you come down and look at this posterior rib fracture? I've got a child that's got a subdural hematoma and they're intubated. Can you teach me how to treat a posterior rib fracture? So this isn't going to be the presenting thing that you're going to see, but it is something for you to know about. Kids under 2 with rib fractures, really, really worry about those. Okay. The next one, fractures of high abuse and specificity. This is the last time I'm going to really belabor this point. So scapular fractures. When you think of scapular fractures, what do you guys think of? High velocity, high energy. I don't treat very many of these. The ones I treat are knucklehead kids who are on the skateboard parks and they hit the ramp and they hit their shoulder and they get a spine fracture, something like that. Or you see, for you guys, you see it in motor vehicle accidents probably more than anything else. These, again, when Kleinman said these are high specificity, he's not taking everybody. He's taking the 2-year-old child and the fractures they're talking about. And it's hard to see, but there's a little tiny irregularity right here at this glenoid. There's also the acromion can have a little tiny chip or off of this, right in this area. Tough one though, because there's actually growth plate accessory ossicles. It can be that they look very, very similar. But these again, it's the mechanism. How often does a 2-year-old child or 18-month-old board up and smack his head down at Snoqualmie Pass? Not very often. You'd know if they were getting in a car accident, right? So these fractures would be very, very high specificity. I saw an 8-month-old where mom says, I don't know how it happened. We know how it happens, unfortunately. These are kids that get their arms pulled and yanked and twisted out. So again, it's almost a traction pull, and you pull these chunks of bone off of the capsule or here. Similar, again, Mark talked about a physeal separation is a similar traction type injury. So again, these are really high in kids out of a certain age. So there's lots of different little fractures, and then the other one was the sternal fracture. Again, high velocity fracture. And if you see that in a 2-year-old, you're going to be concerned. But the bulk of those fractures are in motor vehicle accidents and traumas. Very, very rare. Those fractures are very rare, but we still see. But it's only those little kids. Same thing with the spinous process fractures. So, really, what are you going to see? And that's the biggest thing. What is the most common fracture type in child abuse? So it's a very leading question. Posterior rib fracture, complex skull fracture, long bone fracture, or classic metaphyseal lesion. Any thoughts? Yeah, exactly. It's the long bone fracture is the most common thing. This is a bad question because a classic metaphyseal lesion is technically a long bone fracture, so you won't see this question. But just for us to think about, when you're called down to the emergency room to evaluate for abuse, it's going to be a young child with a fracture of the bone, and is that right or wrong? So the problem with this is many fractures, these are pretty common. So how do you know if it's trauma? How do you know if it's NAT or just A? So history and physical exam, that's the key. So again, really quickly, Mark did an incredible job with physical exam. Include a skin exam, and that's really important because you might be the only child you might be the person that sees this child first, and the follow-up exams might be weeks or days later. So the bruising is going to be important for you to be able to see and examine the whole child. Because it's easy to say, I've got this arm, but it'd be great to palpate the rest of the body to see if there's other associated fussy areas or fractures, okay? So real quickly, bruises, Not all bruises are a sign of abuse. You saw the bruises at the buttock, bruises at the chest, bruises around the neck. Those would be very, very concerning. Little teeny tiny bruises like these at the shins in a 3-year-old child, just fine. So don't think all bruises are bad. This is by some guy named Ken Feldman, and he looked at a couple thousand kids, I think, with the help of some of the primary care docs.
Primary care network,
Yeah. And they found that kids who walk, about 52% of them had bruises, 1 to 11 bruises, somewhere in the fronts of their shins, sometimes on their foreheads and on their elbows, 1 to 11. Kids who cruise, for all of us who don't know, cruising means walking bipedally along furniture or with mom helping them. It doesn't mean you go in cars to the mall and try to pick up girls, but it could. Oh, so those kids, a lot of them have bruises. 2% of kids less than 2% of kids have any bruises under 9 months, less than 1% under 6 months. So just a little bit for you to know. So bruises aren't all bad, but some of them are. Okay. So history is the key in these children with the long bone fractures that you're going to see. They're going to say, what should we do about that? Any long bone fracture must be explained with a plausible. That's actually a bad slide. Let's switch that out. It's really any injury must be explained with a plausible history from both a developmental and mechanical standpoint. These all say the same thing. History must correlate with exam and radiographic findings. What we say in pediatrics is the history must be consistent with the injury. So you guys know the mechanics way, way, way better than I ever will, and I mean that sincerely, but dumb stuff. So if you load a bone, like that femur, like that spiral fracture, the tibia, the toddler's fracture, if you load a bone and twist it, you're going to get an oblique fracture or a spiral fracture, okay? This describes a bending force, but if you put an axial load on a bone, you're going to have a compression and a tension side force, and that's going to cause a transverse type fracture. So if you have a young child and the mom says he climbed up on a TV set and the TV set landed right on him, which is actually a fairly common mechanism for a direct bending force and a transverse fracture, and the child winds up having having spiral fractures of both the tibia and the tibia and the femur, how do you explain that from that fracture? Hard to do. That would be something I'd say that doesn't make as much sense to me. So you guys know the mechanics well. The pediatricians know the development really well. These are some gross motor milestones. So if I had a mom who says, yeah, my son's 4 months old, he crawled out of his crib, and then he plummeted down the stairs. You'd have to say, most kids can't crawl out of a crib at 4 months. You'll get that though. Truly, they don't. Young folks will say. So these are just some nice motor milestones. Rolling over, 2 months is really about 4 months. Sitting without support, about 6 months. Pulling to stand, about 8 months, and walking well, early 11 months, late 12, 15 months, about a year. So those kids are cruising around 9 or 10 months, something like that. But parents who say something that just doesn't jibe, that's something that we're really going to talk about. Okay. So beware of a history that changes or evolves, a negotiated history. When you say, I don't know if that makes sense, he said, what I meant to say was he fell on, it wasn't, the stairs weren't carpeted, they were actually concrete stairs. Negotiated histories that change. History not because of injury, just like we talked about, or no history at all. It's hard because taking a thorough history and going back to that family and saying, are you sure? Let's talk about how many steps was it? When you fell, and you fell on top of him, did you fall on him? Did he fall on top of you? Getting that good history is vital. And the last thing that Mark talked about is late history. If a child's been 3 or 4 or 5 days out, why did that happen? So why is it taking so long to get to you? Okay. So this is the last thing I want to talk about really quickly. So this is kind of going on with the no history. Beware of multiple fractures of different vintages on x-ray. So if I look at this, this is that one child that we just saw earlier in here. Hang on. You can see that little tiny corner fracture from the classic metaphyseal fracture. Everything else looks good. This is the initial. We come back about 10 days later, and you can see that this is healed up, but now you see periosteo reaction of this bone down here. So this child had multiple fractures, no explanation. This is very important to try to evaluate that. Okay, so treatment. These all get better. I don't know of any known cases of growth arrest after these classic metaphyseal lesions, even though they're across the growth plate. The biggest thing is to make sure the patient is not at risk for further injury, okay? So how do you do that? What you do as a resident in Seattle, it's nice because we're lucky in Seattle. We have the social worker on call that can really help us out. So it isn't an official kind of legal thing where you go to the Child Protective Services. You call our social worker. Is Kimberly Curtis here? Kimberly, our social worker, she's just an incredible adjunct, and this is a team thing. She knows so much more about the psychosocial aspects than I ever will, an incredible help. At Harborview, again, notify our scan team or their social worker. You can always talk to pediatrics as well. What to do as an attending when you're somewhere else. Remember, there is mandatory reporting, but utilize the emergency room team, use the pediatrics, and if there's concerns, like we have these children who have CP, could they have a fracture that's abuse? Could they have an insufficient fracture? Yes. Is that your job to figure all that out? Probably. I hope you feel like it is, but if it is, you don't have to feel like it is. Definitely call the major center nearby you, and they can help you out. There are people that are meant to do that. Summary, know the specific injuries, the classic metaphyseal and posterior rib. Remember, those are very age-specific. Long bone fractures are the most common of abuse, and know that correlate with the history, and the history must be consistent with the injury. So, thank you, guys.
One of our social workers used to talk about the Woody Allen image of being tormented by a beast with the body of a rhinoceros and the head of the social worker. So I've immortalized her here. And the point that I want to make is that doing child abuse work isn't isolated work. And there's a lot of different skills that need to be brought to the evaluation. If I saw a kid with a midshaft femur fracture at 6 weeks, I wouldn't try and put the spike on myself. And in the same way, you folks shouldn't feel that you have to do the full evaluation yourself. And it's really not just our in-house medical related colleagues, but we're collaborating with the community investigators, the CPS and protective services on these evaluations. When we're called, I think of our role as sort of narrowing the diagnostic uncertainty. You know, you've got this child with a fracture. You're a little bit worried about it. Do you report? Do you put the family through all that rigmarole? It is possible to do some other evaluations to see, yeah, is this something I really ought to be worried about? Or is it something that really fits with normal injuries? And get us involved so we can help you out with that question. When we're thinking of the history, you'll see that the first 3 points we're thinking about, are there unusually susceptible bones to injury? Is this the sick premature infant who had chronic lung disease and who has osteopenia of prematurity? Is there a family history that might suggest OI? Is there a dietary history that would suggest inadequate intake of the nutrients for normal bones? As Tom mentioned, what's the child's development? What's their capability of injuring themselves? And then we get down to the event itself. And we're not going to accept a history, he fell yesterday, because you don't really have any specifics on that. You need to know who was the caretaker. Did the caretaker actually observe anything? Did they hear it? Did they see it? If they did, what did they observe? Where was the child before the event? What happened in the event? What was the child's position afterward? How did the child react to that? We look at timing these injuries. Usually if you have a toddler who has a complete break of the femur, all we have to do is go back into the history to when the kid stopped walking and stopped bearing weight, and then we know when the injury occurred. When we evaluate these kids, as Mark said, under 6 months of age. We generally will image the head because we recognize that our physical exam and our history isn't very sensitive for cranial injury. We'll also do the skeletal imaging. We'll do a full physical exam at all ages, looking for primarily skin injuries, but also kid doesn't move this arm very well. It seems a little swollen and tender. Once we get above 6 months and up to about 2 to 3 years of age, we can drop out the cranial imaging, but we're still going to image the skeleton because there's good data that our physical exam isn't very sensitive to the types of fractures that abused children get. Above 3 years of age, those abusive fractures are less frequent, and generally the kid's getting old enough that they can provide a history and the physical exams more reliable. So we'll only do x-rays of areas where we've got good history or good physical findings to suggest problems. When you're out in the community, you want to make sure your radiology service is doing good studies. You don't put the baby on the top of an adult chest film and snap the whole child and say you've done a skeletal survey. It takes about 18 specific focused x-rays, and make sure that your radiology facilities following the American College of Radiology standards on that. We have problems with a lot of these infants, particularly growth plate type of injuries, like the films that Mark showed at the elbow. I've seen a lot of kids who are seen in emergency rooms have films that are read as normal, yet the child still isn't moving the arm, and I'll see him back in a couple weeks' time, and there's a lot of periosteal reaction because the child's actually had a Salter fracture at the elbow. So we need to use some ancillary imaging sometimes for those kids who are not yet ossified. I've found that an ultrasound's really a nice test for those elbow fractures, but MRI and CT can also be helpful. Generally, our imaging method of choice is the skeletal survey because it's going to tell us there's an injury here, it's a fracture. Based on the appearance of the fracture, I can tell something about the mechanics of the injury event, and based on the degree of healing, I have some idea about when that fracture occurred. So we're getting a whole lot of different results from that one study. If the child's going to be safe, that is, we're going to discharge him to foster care, or we've got a protective parent and the likely abuser's been arrested, then I'd feel comfortable waiting and doing a follow-up skeletal survey because I know that we miss fractures acutely on the initial skeletal survey, particularly rib fractures, non-displaced long bone fractures are often very difficult to see but become apparent with healing. On the other hand, if the child's going to be at risk unless we have more evidence, those are the kids that I'll do a nuclear medicine scan in. You saw some of our images of rib fractures by 3D on the CT scan. These are really quite useful. You could imagine how nice it is for me to bring those up in court when I'm talking about a skull fracture or rib fractures. And the 3D CT is something the judge and jury are going to understand, where if I put up the plain films, everybody says, what? What are you talking about? We want to document, and those who know me and know my penmanship would laugh about the first point, which is why I dictate. When you're evaluating a child, it's no good if you say he has a broken femur. The second part of the diagnosis you have to make is to E-code it. You have to say why that femur's broken. And if you remember that you're going to E-code all the injuries that you see, That'll help you remember to consider child abuse as a possibility. We want to document well, and that would include photographs or drawings, but a photograph won't pick up induration, it won't pick up tenderness, it won't pick up warmth or swelling. So your notes have to talk about those things also. Hearsay evidence is what we have no direct knowledge about. The child comes in and says, "My uncle beat me." I didn't see anything, I didn't hear anything, and normally that would be excluded from the courtroom. But there are exceptions to that where the child's hearsay or the hearsay by the parents can be brought to the courtroom. One of the hearsay exceptions you'll be involved in is when the child comes to the doctor for diagnosis and treatment and provides a history of the injury scenario. There's a presumption they're giving a truthful history because of their desire for appropriate treatment. So history provided in the context of medical diagnosis and treatment is allowed in the courtroom if you've obtained it and documented properly. So I'm not going to go up to that child and say, "Oh, I see your uncle beat you." I'm putting the words in his mouth. On the other hand, if I ask him, "Are you sore?" "Yeah." "Where are you sore?" "Here." "What happened?" "My uncle beat me." Tears come down, and I document the interplay of question and answer and the emotional response, then that's valuable information that'll get into the court system. In a similar way, we want to be sure to attribute statements to who said it and what the context was of how the statements were said. This is an emotional and difficult issue to deal with, and I think as physicians, we always feel very uncomfortable interviewing or interacting with families who may have injured their child. But it helps if we remember that our first responsibility is really to the child and the child's health. And also, it may not be the caretakers in front of you who have actually injured the child. With working parents, we've got nannies, we've got babysitters, we've got Uncle Joe who sexually assaults the child. So you may not actually be confronting the people who have caused the injuries. We all get fearful of HIPAA, but HIPAA has specific exceptions for child abuse. So it allows us to communicate with the legal authorities, protective services, and the police when we have concerns for child abuse, and to do so without the caretaker's permission, although HIPAA does require that we should document those disclosures. When you're interviewing a family about an abused child, I find it far more comfortable if I stay in my medical mold. And I'm going through my routine history, what I'm comfortable doing every day. I do the perinatal history, I do the development, I do a review of the systems, I do a family history. By that time, the family's fairly relaxed, and when I finally get down to talking about the presenting complaint and the reason the child's there, everybody's all sort of settled down, and it's an easier thing to approach. If I see a kid with a broken bone and I don't think it fits the history, I shouldn't be going to that parent and saying, "This doesn't make sense, give me a better story." That's the police's job. That's not my job, and we need to stay in our own role on this. However, it is very important if I see that broken bone, could you give me some more description about how it happened? What did you see? How did the child react? That sort of clarifying of details is very important. Recognize your own emotional reactions and try and control them. We have to stay in a professional role when we're dealing with caretakers. And I always think a little dissociation helps, that if I get out of my emotions and out of my body when I'm dealing with these cases. It's a little easier than really riding on the emotions. Remember that most of these abuse cases, the injuries aren't intentional. It's caretakers with limited resources, limited skills, who became extremely frustrated, lost their temper, and reacted inappropriately to the stresses that they're experiencing. But this doesn't necessarily mean they've got horns on their head. As Mark said, we generally notify parents that we're making referrals for investigation. We actually tend to be a little bit cautious in giving the full details. So I might say, whenever I have a child with an injury like this that I don't understand, the law requires me to refer to protective services for further investigation. I'm probably not going to say that I'm also going to call the police to do the investigation, and I may talk about the femur fracture that brought the child in for injury, but I won't be talking to them, oh, and by the way, there's half a dozen different rib fractures here, and we've got a few CMLs, and the kid's got a subdural on the head, because I want the police to have a good chance to have the family a little bit naive to the extent of the injuries when they do their interview and their evaluation. I don't want a lot of stories cooked up before they have a chance to get in there. Remember that there's a high co-occurrence of domestic violence with child abuse, and figure out how you're going to care for your own emotions. I tend, when my feet at least don't have the plantar fasciitis that they have now, to go out running with my colleagues in order to get my head back straight on. But you ought to have some way that you deal with your own mental health on this. Report when there's reasonable cause to believe, and there's immunity from liability for reporting, yet there's sanctions for you if you fail to report. When you get a subpoena, call us, call your hospital's risk management for advice. It's not like the medical liability, it has its own special intricacies. Here's our Washington state laws that are involved with child abuse. Again, reporting is reasonable cause to believe. 1334, the dependency laws, and then 916-100 talks about parents having the ability to use reasonable discipline on children, but different things aren't reasonable, like cutting and burning and hitting an infant on the head. Remember that there are resources. You probably, wherever you are, will have some social work staff referring to community agencies, CPS, police, public health nurses can be helpful. Within the Seattle area, going through our child abuse program can be helpful. Washington State has a child abuse consult network, and the American Academy of Pediatrics online has its section on child abuse and neglect, so you can find out who locally has interests in child abuse. Remember your role as physicians, our responsibilities to the patient for good medical diagnosis and treatment. CPS and their attorneys are responsible for protecting the child, but they have a dual responsibility for maintaining or reuniting families, if at all possible. And the prosecutors and police are concerned about the perpetrator, and is there a criminal event that they need to prosecute. And if we remember that each of us are in those different roles, you'll be a little less frustrated about why aren't they responding appropriately to this event. And finally, I'd just say that in Washington, the assault statutes are based both on the level of intent and the level of injury. And most of these aren't intended injuries, they're acts of passion. So they're usually going to be second-degree types of assaults. And here's some of the resources for you.
So that's a great discussion and 3 great talks. We appreciate it very much, and thank you guys.